So, is there the next speaker, Nupur Dubey, is present? Our topic is corneal perforation. Is there a hope?
So, whenever we encounter a patient with a corneal perforation, the first question that comes to the mind if there is a hope. So, today we'll discuss various management strategy for corneal perforation along with some of the cases that I have come across. So, corneal perforation is a true ophthalmic emergency which, if not treated on time, can lead to devastating complications. These are the various management options which are available. We can choose the best suitable option for our patient depending on the size, location and etiology. We'll discuss each option one by one. So tissue adhesives are more suitable in the perforation which are less than 3 to 4 mm in diameter. We can either use a cyanoacrylate glue or we can use a fibrin glue. Cyanoacrylate glue is preferred in such condition because it is cheaper, stays for a longer time, has bacteriostatic properties and provides more tectonic stability to the globe as compared to a fibrin glue, which is generally used as an adjuvant to Tenon's patch graft or an amniotic membrane graft. So there are various techniques of application which have been described. I prefer to apply with the backside of a Vexel sponge, which helps to apply a very thin layer of glue over the site of perforation. Two very important points that have to be kept in mind is that debridement of adjacent epithelium has to be done and the area of application has to be kept dry throughout the procedure so that the glue holds well. Anterior chamber, whenever required, can be formed with the air or viscoelastics. Especially it is useful in the cases where the aqueous keeps oozing out and we are not able to apply the glue. In such cases, we can just put an air bubble into the AC, which helps to temporarily block the aqueous oozing, and then we can go ahead with the glue application. So this is the patient who came to us with a perforated corneal ulcer, and we did a TA-BCL for the patient. This is how the patient eye looks like after 3 months. Perforation is well healed, and at this stage, we can plan any visual rehabilitation procedure for the patient. This case I have kept to emphasize on the importance of correct technique of application of glue. This patient came to us with a history that TA-BCL was done elsewhere a few days ago. BCL kept falling off and he was complaining of extreme foreign body sensation. So we can see due to excessive glue application, the mound of glue has formed. So we had to take the patient back into the OT. We removed the glue and reapplied a very thin layer of glue, after which the patient was very comfortable. Coming on to the patch grafts, so in peripheral or paracentral small perforations, we can use a lamellar or full thickness corneal patch graft. For example, this patient came to us with a peripheral corneal ulcer with perforation in the flat AC. So we did a corneal patch graft for the patient. Similarly, in this patient also came with a corneal ulcer and a perforation. We did a TA-BCL for the patient, but after 1 week, patient came with a reperforation. We repeated the procedure, but patient was doing well, but after 1 month he came again with a perforation and a flat AC. So eventually we had to do a corneal patch off, and this is how the eye looks after 1 week of doing the surgery. Similarly, this patient, a very young lady, came to us with a peripheral perforation with a 7 to 10 days history of blunt trauma and a iris prolapse. So we upsized the iris and did a peripheral patch graft, and she did very well in the post-op period. This was a very unusual case. A 65-year-old lady came to us with a history that she was taken up for cataract surgery, and after administration of peribulbar block, when she was taken to the OT, the surgery was cancelled and the eye was patched, and she was referred urgently to a cornea surgeon. She came to us after 3 days when we noted superior corneal thinning and multiple site perforation. This is how the other eye looked like. So we had to eventually perform a lamellar crescentic patch draw for the patient, and she did well. So in the cases of peripheral larger perforation which cannot be managed with glue alone, we can use a multi-layered AMG along with overlay sutures and the fibrin glue. So it's especially useful in the cases which are associated with the aqueous deficiency disorder, for example, rheumatoid arthritis. But AMG, what it does, it gets integrated into the healing stroma and provides tectonic stability to the globe. But it cannot be used in the cases of infection. Similarly, Tenon patch graft is also very useful in the cases where scarcity of the corneal tissue is a problem. It is also indicated in the perforations which are secondary to an underlying autoimmune etiology and not infections. As it is an autologous tissue, there is no risk of tissue rejection or need for long-term corticosteroid therapy. In the cases of central large perforated corneal ulcer, therapeutic keratoplasty is the only option. But there are so many challenges that we face during TKP in a perforated cornea. So first, because of excessive hypotony, trepanation is very difficult. Flaringa ring is very useful in such cases. Even after that, chances of injury to the iris lens complex during trepanation are very high. So AC always has to be formed before trepanation with the viscoelastics. And in fact, we can just make a superficial mark with the trephine, and then hose button can be excised with the help of a side port blade and a corneal scissors. So this is a patient who came to us with a central large corneal perforation, and we did a TKP for the patient. Within a few months, patient developed a cataract as well, intumescent cataract, so we had to perform a cataract surgery as well for the patient. This lady came to us for manual SICS we performed, and the post-op course was uneventful. After 6 weeks of surgery, she came to us like that. When we reviewed the old record, there was a scar which was mentioned in her records, which was missed, and so we suspected a recurrence of the viral keratitis. We initially tried a glue BCL for the patient, but didn't work, so we eventually had to perform a eccentric large graft for the patient, and she did very well. This is a very young guy who presented to us with a fungal perforated corneal ulcer. We did a TKP. This is how the eye looks like on POD3. Unfortunately, the patient developed a graft failure, but we were eventually able to rehabilitate the patient as we performed a second surgical intervention, phakic DSEK, and patient was able to get 6/18 vision after 4 months of surgery. So to conclude, yes, there is a hope provided timely intervention is done in such cases. Primary aim should always be to restore the integrity of the globe and control of any infection if it is present. Secondary surgical intervention can be done once inflammation is well under control. Whatever we do, good patients counseling regarding long-term follow-up and need of multiple surgical interventions is the key to success. Thank you.
Thank you, Dr. Nopur. You have covered everything in this topic, and it is a common problem, corneal perforations in all our OPs, general OPs. We see most of the cases in our OPs.